Uh, Now we will go to the next case. Uh, the next case, I will request Professor Ghiyas to please have a seat. And now I will request Dr. Professor Israr Ul Haq to please come on the stage. He's the head of Department of Medicine unit in Mayo Hospital, Lahore. After him, I will request Professor Shahid Sarwar to please come on the stage and have a seat. Professor Shahid Sarwar is the professor medicine and Dean of Internal Medicine, Allama Iqbal Medical College. Professor Shahid Sarwar is actively involved from BLS to EUS conferences. I will request Professor Shahid Sarwar to have a seat, please. Now I request Dr. Faisal Hanif Saab. He is the head of Department of Liver Transplant Unit, Bahria International Hospital. His area of interest is hepatobiliary and pancreatic surgery. We welcome Dr. Hanif. Please have a seat. Now I request Dr. Anisur Rehman Saab to please come on the stage. He is the senior consultant radiologist, clinical lead for PET CT and body imaging and working in Shaukat Khanum Cancer Research Hospital. I would also request Dr. Sabeen Farhan to please come on the stage. She is a consultant gastroenterologist working in Shaukat Khanum Cancer Hospital, Lahore. I welcome all of you. And for the presenter and moderator, first, I will call Dr. Imtiaz. He is the moderator of this session. He is our fellow gastroenterologist in Jinnah Hospital, Lahore. I will also request Dr. Habib. He is the senior registrar, gastroenterology department, Mayo Hospital. I welcome all of you, sir, and thank you very much for your time.
The case we are going to discuss today has been challenged for us for the last 1 year, and we are very hopeful by the end of the discussion we'll reach to some solution, inshallah. Dr. Habib, please.
Thank you very much, Dr. Imtiaz, Dr. Vais, and Professor Shah for providing me the opportunity in such a beautiful learning session. Today we are going to discuss the next case, that is of chronic pancreatitis. Pancreatitis, a patient presented, a young patient, 22 years old, presented with history of abdominal pain for the last 3 months, vomiting for the last 3 months, and weight loss of about 1 kg during this period. Pain was moderate to severe in intensity, radiating to back. Patient was taking NSAID with partially and minimal relief of the pain. Patient has recurrent non-projectile vomiting containing only food particles, pain even not settled after the vomiting. Patient have weight loss of about 10 kg over the 9 months. There is no shortness of breath, cough, sputum, or chest pain. Rest of the systemic examination, including the cardiovascular and neurological examination, was unremarkable. No previous or personal history of diabetes, hypertension, and ischemic heart disease. He is a smoker with 2-pack year history. He take alcohol with local made for the last 3 months, about 1 to 2 glass per week. No family history of ischemic heart disease, diabetes, hypertension, or pancreatic disease. Has most of the labs, including the complete blood count, liver function test, triglycerides, fasting lipid profile, serum calcium was normal, except from the pancreatic enzymes, that is amylase of 3.301 and lipase of 314. ABGs were normal. Ultrasound was performed, and which showed the following significant finding. This is the routine report. On ultrasound, pancreatic duct is dilated about 5.1 millimeter. Along with, there is a heterogeneous area measuring 4.8 to 1.6 centimeter along the body and tail of pancreas. Liver is normal in size and texture. CBD is of normal length and diameter, and there is no calculus in the CBD. Gallbladder is normal. The impression of the ultrasound was dilated pancreatic duct with heterogeneous area along body and tail of the pancreas. To delineate this ultrasound finding, further CT scan was planned. CT scan showed an ill-defined heterogeneous area in the head of pancreas. It was about 38 to 36 millimeter with internal calcific specks. It was associated with dilatation of pancreatic duct up to 6 millimeter as discussed in the ultrasound. Liver is normal in size and shape and normal CBD and normal pancreas. Unfortunately, patient lost follow-up after the pain settlement and again presented with severe symptoms of frequent abdominal pain and vomiting for the last 3 days. Now, again, all the labs, including the TLC, fasting lipid profile, serum calcium, and intact PTH were normal. HbA1c was also within the normal range, except for the amylase and lipase level, which are raised with serum amylase of 702 and lipase of 400. Again, CT was performed, and kindly show the CT.
I would request Dr. Anis to please help us to read this CT, please.
Okay, so it was delayed venous phase CT scan of abdomen and pelvis performed, and we can see that the pancreas is slightly atrophic and irregular in the region of tail with the cystic dilatation of the pancreatic duct, which is likely continuous with the dilated pancreatic duct, and we can see that the significant dilatation of pancreatic duct noted all the way through the body and extending to the head, containing multiple calcific density areas. These are more concentrated in the head area, where there are crowded, slightly ectatic pancreatic ducts with more dense and punctate calcifications. We can see the normal outline and shape of pancreatic head is lost, and it is inseparable from adjacent pancreatic wall. The fat haziness is present. So overall, like if this patient is coming first time and I'm reporting it without, like I know that this is diagnosed as chronic pancreatitis, but I should also put a differential in which the IPMN should be included in the differential as well. And the changes in the pancreatic head are very suspicious of any ongoing phlegmon formation. So it should, I will say that at least there is some partial acute on chronic pancreatitis which is affecting the pancreatic head. There are chronic changes of duct dilatation with calcifications, which are more indicative towards the chronic pancreatitis. Otherwise, we can put IPMN in the differential as well.
Thank you, sir. I would like to take the opinion from Professor Ghiyas. Patient has 2 episodes of pancreatitis with raised amylase lipase, and this is the CT in front of us. Sir, can you guide us further? How should we proceed?
देखिए एट द एज ऑफ 21 अगर आपकी डक डायलेटेड आ गई है पैंक्रियास की और देयर कैल्सिफिकेशन स्ट्रेट वे वी नो दैट दिस पेशेंट सफरिंग फ्रॉम chronic pancreatitis. Now this patient has been having some recurrent attacks of pancreatitis, but the number of subclinical attacks we don't really know. At his age, what are the possibilities? Can it be because of the gallstones? He's too young for that. Can it be because of the hypercalcemia? Calcium levels are 8.9. Can it be because of hypertriglyceridemia? The triglyceride levels are 107. IG4, a new entity, and we have started to see more and more number of cases of high IG, but are they really translating or are they really converting into IG4 related pancreatopathy as well? My trick is to just give a trial of steroids. If the patient gets better and gets better in 3 to 5 days substantially, I take it as IG4. Otherwise, I take IG4 as just an acute phase reactant. And finally, genetic. This is the age, although in the history they have said that he has been consuming alcohol as well, till the age of 21, कितनी alcohol पी लेगा? कोई ये तो नहीं कि वो वक्त अल्कोहल में नहाता रहेगा. सो इट्स जस्ट आई थिंक जिसने हिस्ट्री बनाई है उसको वो जैसे होता है ना MCQ में थोड़ा सा डाइवर्शन देने के लिए, लोगों को गलत डायरेक्शन देने के लिए कि पता नहीं को पिक करता है नहीं करता, वो उसने बीच में तड़का डाला है. बट अदरवाइज टिल द एज ऑफ 21 कितना पी लेगा? मे बी once a week, once a month, and that too in a limited quantity. So message is that till the age of 21, we don't expect the person to be consuming that amount of alcohol, that the whole thing may be because of alcoholic pancreatitis. So all in all, it is most likely a case of genetic pancreatitis. Now, genetic studies are not available in Pakistan. On special basis, children hospital people are doing it, and we keep sending the patients regularly to Dr. Anjum over there to take the sample, and we get the result back in 2 or 3 months' time. Now, even if we get the positive mutation, and that's usually the case that in majority of these cases, these young people from 15 to 25 who present with pancreatitis, recurrent attacks pancreatitis, they have genetic pancreatitis. Even if the mutation results come back as negative, positive, at this stage, we have to think in terms of management. And as we go along, we'll come down to the management. But diagnosis-wise, I shall say that this is a most likely case of genetic pancreatitis. At his age, considering the cystic lesions of pancreas like IPMN, which usually occurs in the people above the age of 55 to 60 years, will be relatively, on clinical grounds, unfair. Radiologists, they always keep thinking in terms of these things, maybe these things, but then we try to correlate more on the clinical grounds. Okay, at this age, we think that IPMN can present. So IPMN, definitely not. Chronic pancreatitis, calcification, dilated pancreatitis, straight-ways chronic pancreatitis, cause most likely genetic.
Thank you, sir. Professor Faisal Hanif, patient is very desperate with the pain, and he wants his opinion. He wants your opinion for his pain. Do he need some surgical intervention at this stage?
देखिए chronic pancreatitis में 2 reasons होती है पेन की. एक है ductal obstruction, दूसरा है parenchymal inflammation and ischemia. Now we have to decide what is the dominant thing. Duct dilated है, so for all practical purposes we take it as ductal hypertension, and maybe inflammation and ischemia may be coexisting, but the achievable target is decompression of the duct, so that's the way to go.
So I think I'll come to pain in a second. First, I would like to continue with Professor Ghiyas' previous comment regarding the etiology. One important thing is that in young patients, if you expect there is congenital, is a genetic origin pancreatitis, another role of checking for their genetics is that you want to identify if there are any members in the family as well, because there is very high risk of developing pancreatic cancer in those patients who have chronic pancreatitis due to that reason. You also want to know if there are any family members, and then you can put them on, you also test them, and if there is anybody who is positive, you can put them on surveillance. As far as pain is concerned, so microcalcifications sometimes cause inflammation which are in the pancreatic body. They can cause pain, and because of the blockage of the duct when it is dilated, the blockage itself causes pain because of the pressure which is built up in the pancreatic duct. So it's very important to first understand the etiology of pain. If the duct is not dilated, in this patient the duct is dilated, but if the duct is not dilated and there is only chronic features of chronic pancreatitis with calcifications and stones in the body of pancreas, those patients do not have any benefit from surgery. However, those patients in which there is ductal dilatation, they will benefit from surgery, but I prefer them to have first ERCP and stenting of the pancreatic duct, because if that is successful, you may be able to reduce the pressure in the pancreatic system, and that will alleviate the pain. If that is not successful, then they are candidate for surgical intervention.
Thank you, sir. I would like to take the opinion from Professor Israr. As we know, we don't have too much of genetic investigations. What further investigation should we advise to the patient?
According to the history, the pain is typical of the pancreatic origin, starting with the pain associated with vomiting and associated with severe intensity of pain along with vomiting, and which is recurrent. In addition of this history and with this CT evidence of pancreatitis, then the straight away along with the weight loss of 10 kilo, which is significant. Chronic pancreatitis is number one differential, and second could be the malignancy of the pancreas or the gallbladder area if the CT evidence was not there in the initial phase of presentation. then these 2-3 presentations are there. In addition, fasting lipids, calcium levels, ultrasound as a screening test for the gallstone disease, history of alcoholism, IgG4 levels, these are the initial workup which have already been done.
Thank you, sir. Dr. Sabeen, you want to add something, please?
So just one thing that I want to add here is that, it's already been said that we want to try to establish what the etiology of the pain is. But while we're actually working up, there's some things that we should reiterate from the very beginning, that the patient really has to stop smoking, the patient has to stop alcohol. We can start off with various measures, checking for evidence of pancreatic, of exocrine insufficiency, checking the fecal elastase, putting the patient on creon. And along with that, because two things basically are here that will really influence our management. So it's really important. Now, here the CT scan that has been done is a single phase. It's just a delayed phase. So basically now there is a suspicious mass, though very, very suspicious of very suggestive of chronic pancreatitis. It's really essential that we do a proper triphasic CT so as to categorize what that mass is, and then obviously do an MRCP so as to establish what the pancreatic ducts look like, whether there is any evidence of any dominant stricture there as well.
Thank you, madam. We buy your opinion. So
I just have a question. We know that the people who are going to benefit from surgery are those where there is definite obstruction and pancreatic duct dilatation. But primarily these are the patients for going ahead with the ERCP and stenting. So is there a cutoff of duct size where we should decide that no, this is not a candidate for ERCP, we should straight away send him considering the age and the pain in which he is continuing for last 1 year?
देखिए, अगर तो हम वेस्ट का लिटरेचर देखें तो chronic pancreatitis with dilated duct, the preferred mode of management is surgical. The Asia Pacific experience tells that preferred mode of management is endotherapy. And the experience that we have in the past 10 to 12 years, it is very safe to say that, I can say that in almost, I would have dealt more than 600, 700 cases of chronic pancreatitis with endotherapy. How many cases did I really send to surgeon for endotherapy, for the surgical management? I can count them on fingers, maybe 5 or 6, not more than that. And how many surgeons are there who are doing pancreatic tracheostomy? Faisal is here. There are a couple of, or 3, 4 more. Faisal can tell us about his experience, how many times that we really need to go for surgical pancreatic tracheostomy, and the morbidity and complications which are associated with that procedure, that also needs to be considered. The endotherapy is, with the new gadgets that have come, the long-standing historical experience that we have with endotherapy, that is not valid anymore, because the new gadgets which have come up and the new therapies which have come up, it has revolutionized, changed the whole scene altogether.
Thank you, sir. Dr. Habib, please.
Thank you, sir.
So I think I personally, to be honest, I personally prefer, especially if there is a stricture at the pancreatic head level, if that can be dilated and the rest of the duct is looking okay, only that is dilated but there is no multiple stricturing. I prefer in all those patients to have at least a trial of putting a stent in. And if that doesn't work out, then obviously I would go for surgery.
Problem with stenting is that you have to repeat the session. Maybe every 6 months you increase the number of stents. So how do you balance out the number of procedures that he has to undergo compared to one-time procedure considering a grossly dilated duct?
So from surgical point of view?
From
surgical point of view, especially so there are 2 common procedures. One is Fry, another one is Pusto. Pusto is more for those patients who have a dilated pancreatic duct but their head is not that bad and is not that inflamed. In those patients, you just do a longitudinal pancreatic angiogenestomy in the dilated part of the duct, and that is usually good enough to drain the duct and relieve the symptoms. However, if the head is massively swollen, and as in this patient, then doing a simple pancreatic angiogenestomy usually do not relieve all the pain. And they keep on getting symptom from the part of the duct which is going into head and all that. So then classic Fry or modified Fry is preferable, in which you have to resect the superficial or superior part of the head and open up the duct up to the level of head, and then do a pancreatic vaginostomy.
Thank you, sir.
Dr. Shahid, coming down to your question that single procedure versus multiple procedures that we have to do. You see, restoring the normal passages, that is always beneficial as compared to creating a new stoma, a new pathway. So as long as we are able to restore the normal pathways, irrespective of the number of procedures, that doesn't really matter. And number two, stricture management. It all comes down to the experience and energy of the person who's doing it. If the stricture is soft, we can go up to the maximum dilatation right on the index procedure, and we can put in 2, 3, or 4 stents as well. But if the stricture is too tight and patient is having a chronic issue, stricture is fibrotic, in those scenarios, maybe in the first case, in the first index procedure, we may be able to pass a single stent, and then on the subsequent procedures, we can upgrade the stricture and pass more number of stents.
Thank you, sir. We got the MRCP of the patient, and I request Dr. Anis, can you please read this MRCP?
Yeah, the MRCP was performed. It was mainly targeting the pancreatic ducts, not focusing very much otherwise unremarkable bile ducts which are not dilated at all. So in the pancreas we can see the almost similar finding as we noted in the previous CT scan, significant dilatation and multiple signal void areas suggestive of intraductal calcifications. These are more crowded in the pancreatic head area over here. So I didn't add anything much from our previous CT scan.
Thank you, sir. Can you please? Now we have recurrent pancreatitis, we have CT, we have MRCP. I would like to take opinion from Professor Israr. How should we proceed further? But patient is not improving at all.
Modalities, and we have to switch for the therapeutic modality, which is ERCP with pancreatic stenting, and we'll try to decompress the pancreatic duct with the hope that it will settle the symptoms.
Thank you, sir. Dr. Habib.
ERCP was performed, ampulla was identified, and it showed normal CBD and intrahepatic biliary dilatation. Pancreatic duct would not be cannulated through major papilla. Minor papilla was prominent, identified with expulsion of whitish discharge. Failed cannulation of pancreatic duct. This is the ERCP.
I would request Professor Shahid, can you please comment, was this the right decision to go for ERCP? What was the rationale behind the ERCP?
But that we have already discussed because the duct was dilated and patient is continuing to have pain. So ERCP was meant to relieve the pressure symptoms because of the occlusion or the blockage of the duct. So that decision was the right one. Obviously, in a situation where you can't manage to cannulate, that needs another attempt, or attempt at a center with higher load of pancreatic ERCPs. The decision, as we have already discussed, is justifiable in this case.
Thank you, sir. Please proceed forward.
Just to add here again, what we can do in these cases is that, obviously, just reiterating what Professor Shahid said, that another attempt at ERCP at a center which has a high bulk, a high volume of pancreatic ERCPs. And even if that fails, then obviously going for a rendezvous, an EUS guided rendezvous, trying to place a wire through the pancreatic duct, bringing it out to the papilla, and then doing retrograde, and then doing an ERCP through that.
Thank you, sir. Thank you, madam. Next.
So after the failed ERCP, patient symptoms did not resolve. Patient again developed epigastric pain, vomiting, and decreased oral intake on 18th January 2025. Her labs repeated that again showed increment in serum lipase and amylase. Otherwise, hemoglobin, liver function test, alkaline phosphatase, and creatinine was all normal. CT was again performed.
While the images are opening, just want to give one message that whenever we are scanning pancreas, kindly do the pancreatic protocol scan, which should include slightly late arterial and venous phase to see the details of the vessels as well. So again, we can see that atrophic pancreas with dilated pancreatic ducts. Small calcifications are again seen. There are some haziness and fat obliteration around the pancreatic head, which may reflect maybe a subclinical, maybe mild acute pancreatitis as well. Duodenum is dilated and there is no other significant abnormality, no gallstones, no intrahepatic cholestasis.
Thank
I
you,
know
sir.
the ARCP says pancreas divisum, the possibility pancreas divisum, but CT and previous MR, they are clearly indicative of dilated main pancreatic duct with a possible focal stricture only. The calcification is there in the parenchyma, it's not really in the main pancreatic duct, although stum floaters are there in the main pancreatic duct. So all in all, I can say that it appears to be a standard normal anatomy of the pancreatic duct. Though the ERCP report suggests the possibility of pancreas divisum. Let's see, what do you have next?
Okay, next.
CT report show liver measures 14.4 centimeter with normal parenchyma with normal biliary channels. Gallbladder is normal. Multiple dense variable size calcific foci seen in the region of head and body of the pancreas with mild focal swollen appearance of pancreatic head. Pancreatic duct appears dilated in region of body and tail measuring 3.5 millimeter. No peripancreatic fluid collection seen.
Thank you. आई वुड रिक्वेस्ट प्रोफेसर शायद सर पेशेंट की सिम्टम्स इंप्रूव नहीं हो रही, वो बार बार सेम कंप्लेंट साथ आ रहा है. ERCP वी अटेम्प्टेड बट वी फेल्ड. हम पेशेंट को कैसे कंफर्ट कर सकते हैं, कैसे उसको फर्दर हम लेके चल सकते हैं, बिकॉज पेशेंट को 3 अटैक्स हो चुके हैं, ERCP फेल हो चुकी है और ऑल इन्वेस्टिगेशन इन हिज हैंड, बट स्टिल पेशेंट इज इन सेम प्रॉब्लम.
This is a typical case of acute on chronic pancreatitis. He's repeatedly having attacks, and every time the mileage lipase is raised. And most of the time that your diagnosis of chronic pancreatitis is clinical. It's based on his symptoms along with the imaging modalities which augment those clinical suspicion of chronic pancreatitis. Because the tests that we have for chronic pancreatitis, they have very low sensitivity. We do advise stool for elastase and chymotrypsin. These are the things which only become positive in a certain number of patients because needs a major exocrine insufficiency for these tests to be positive. And the rest of the tests are basically invasive. We are aware of CCK stimulation and all those. They are basically theoretical tests. So diagnosis is chronic pancreatitis. One, we have discussed that he needs an intervention because there is a possibility that if we are able to put stents in pancreatic duct, that will help in alleviation of his pain, of the symptoms that he's having. And obviously that will need to be increased to a certain diameter as Professor Ghiyas has shown. And the second thing now we have to focus is on the medical management of this patient, or to focus on his symptoms. One is his pain, the other are his exocrine and endocrine insufficiencies which needs to be addressed in his management.
देखिए ना, अभी तक तो उसकी एंडोक्राइन इंसफिशिएंसी कोई नहीं आई. पेशेंट इज नॉट डायबिटिक. एक्सोक्राइन इंसफिशिएंसी, our experience about exocrine insufficiency in the patients, especially genetic pancreatitis, is that not many patients who have got exocrine insufficiency, unlike people who are suffering from cystic fibrosis, where the exocrine insufficiency comes early. In people who have got chronic pancreatitis in our part of the world, somehow exocrine insufficiency needing pancreatic replacement therapy and getting really real help from them are not many. Yes, they do get help with decompression of the duct because ductal hypertension is the one which is giving rise to the pain. Pancreatic parenchymal ischemia, in how many percentage cases, giving strong antioxidants to them, giving antioxidant drugs, diet therapies to them, do they really help? But in terms of pain management, it has to be a combination of the things. Pain management clinics, use guided celiac neurolysis in these patients, giving them pain modifying agents, psychotherapy, social managements. I think it has to be a multi-modality management in these patients. Mind you that these patients, they are in the age group where they get dependent to the drugs, or especially the opioid drugs, very quickly. So one has to be vigilant to that thing as well. The number of cases where we have successfully managed the patient, and we have to counsel the families of the patient that, look, there's no rise in the amylase lipase after the therapies that we have given, and the child is coming back with the pain. Now it has to be drug dependence, and when the people work on the drug dependent side, the people come out of this pain business and all that. So it has to be multi-modality management in these patients in terms of pain. But for the ductal dilatation, we need to effectively manage the ductal obstruction.
Just one thing. Still one question. That epicenter of the pathology, it appears to be in the pancreatic head. Either there is phlegmon formation, ongoing acute and chronic inflammation, there are ectatic duct, there is soft tissue bulk, fat obturation is there, and then distal to it, the duct is dilated, so likely the epicenter is in the head. So it can be a phlegmon, it can be anything. So what's the role of EUS and tissue diagnosis to confirm and to exclude any more sinister pathology or anything which is causing this obstruction? Because we are not seeing any sizable stone as a cause of this obstruction.
देखिए, जहाँ तक तो diagnosis का सवाल है, for us, we take EUS as a mode of intervention. The imaging tools that we have, dynamic EMA with EMA-CP, the new CT scans, they are much superior as compared to the endoscopic ultrasound. And let me tell you and openly confess that for EUS, the radiologist's eyes are much quicker and much sharper as compared to us. We can never match them because they have been trained and they have been raised up looking at these black and white images. For us, EUS means intervention. I shall take it as if I fail the ESCP, I shall take it as an opportunity to go through the stomach and puncture the pancreatic duct from the stomach, put the guide wire, push it through down to the duodenum, and take a rendezvous approach if I fail the ERCP. If I find an abnormal lesion, and my radiologist colleague has pointed out that, look, this area looks suspicious, go for the biopsy of that. I shall go for targeted biopsy with the help of endoscopic ultrasound on that. But making a primary diagnosis, picking up a primary pathology just on the basis of EUS, in 99% of cases, I shall say that my radiology colleague would have already pointed out that this is the abnormal area that you need to focus on and you need to take biopsy. Per se, on endoscopic ultrasound, finding something new, maybe in islet cell tumor, that's the only scenario where I find EUS to be of any advantage, but otherwise, no.
Thank you, sir. I would request Professor Sabeen to please enlighten us about the EUS-guided celiac block. Can it helpful for this patient, or should we go for this one?
So yes, initially you can start off with pharmacological measures, but like Professor Ghiyas already said, this should be basically through the multidisciplinary team. And there are usually pain clinics where patients basically can simply start off with simple pharmacological measures, starting with paracetamol, opioids, gabapentins, SNRIs. And if those things don't work, then obviously you can go to EUS-guided blocks, neurolysis, those kind of things can be done. Now, basically, when you're doing an EUS, you basically have a very good approach when you basically go just below the geo junction, you can identify where the celiac takeoff is coming off. And targeting that area, yes, you can go for celiac excess block, celiac plexus neurolysis. You can also go for extended ones where you can basically inject below the, and covering both the plexus at the level of the celiac axis as well as the SMA, so that those can be more extended as well. But again, I don't think that should be the first line. The first line should again always be pharmacological measures. And again, reiterating, stop smoking, stop alcohol.
Thank you, ma'am. We will also like
before we get confused, especially in this patient has a dilated obstructed duct. So that needs to be dealt with. If it can't be dealt with endoscopy, that has to be dealt with surgical. So all these measurements, pharmacological and EUS-guided blocks and all those are required in those patients when there is no treatable cause. In this patient, there is a treatable cause for his pain. And another important point is, as Professor Ghiyas mentioned, for example, in this patient, every time with his pain, his amylase and lipases go up. That shows that his exocrine function is still there. And to preserve that exocrine function, it is even more important to drain his duct. Otherwise, what will happen with these recurrent attacks of pancreatitis, his exocrine function eventually will go away.
Thank you, sir. Would also like to take a question from the audience, please. Anybody who have a question? Anybody having any question, please? I'm very thankful to the panel of experts having a detailed discussion about the very challenging case. We are actually dealing with this case for the last 1 year, and he is presenting to us with a same symptom again and again. Thank you so much.
Get his duct drained.
Ladies and gentlemen, now we have a tea break for 15 minutes, which will be finishing by 11:45, and we will expecting every one of you to be participating in the next session as well. There are 2 cases yet to go, very challenging scenarios, and we have expert panelists. I will request our expert panelists and faculty, they have an arrangement in the principal office, and for our worthy participants and audience, we have an arrangement in front of auditorium. So come back in 15 minutes so we can continue with this discussion. Thank you.